Hello. I'd like to talk about carpal tunnel syndrome. Carpal tunnel syndrome. This usually occurs when somebody feels numbness, tingling, and pain, primarily involving these first three fingers of the hand. Occasionally it can happen to somebody that does repetitive activities, such as using a keyboard, heavy lifting, or it can happen in some patients that are pregnant or notice any shift in their body habitus or their fluid status in the body. But either way, what it comes down to is compression across the median nerve. The median nerve is a large nerve that runs through the center of the wrist and innervates these 3.5 fingers here. Occasionally, patients will notice pain, numbness, tingling, and sometimes when it's really bad or where it's been going on for many years, they can notice atrophy, which means the muscle starts to waste. Particularly this muscle, which is called the thenar eminence in the hand, and this is primarily the muscle that you will see start to shrink. When it gets to the point where this muscle starts to shrink and you are dropping objects because you're having so much weakness in the hand, usually that means that some of the nerve damage may be irreversible. So it's important to understand that if you do have any nerve symptoms, that you be evaluated. The standard approach for carpal tunnel syndrome is a conservative approach, depending on how long you've been dealing with the symptoms. If you have these symptoms acutely within a few months, typically what the physician will do is in a standard exam confirming that you have numbness and tingling in these 3.5 fingers and that you do not have any atrophy or weakness in this thenar eminence. If that's the case, usually an anti-inflammatory and a night splint may help, because some patients have what's called transitional carpal tunnel. If a patient comes in and says, I only have numbness and tingling at night, but during the day it goes away, more than likely it has to do with the position of their hands when they're sleeping. Some patients will sleep in what I call the praying mantis position, whether on their belly or on their side with their hands flexed and their elbows flexed. This puts pressure on this median nerve and actually can irritate the nerve and create carpal tunnel symptoms. This is quickly and easily addressed by just using a night splint that they wear at night when they're sleeping that keeps their hand in a neutral position and prevents them from rolling it at night. If that takes care of the symptoms, that and an anti-inflammatory, then more than likely they had transient carpal tunnel, and this will usually resolve. If, on the other hand, they notice numbness, tingling, and weakness throughout the day, not only at night but during the day as well, then we will go ahead and try the night splints as well as an anti-inflammatory, but typically we will get what's called a nerve conduction test, or an EMG, which tells us how bad the carpal tunnel or how bad this median nerve is being compressed, and it can grade it mild, moderate, or severe. That will usually determine the next step. If you have a patient who has not responded to conservative measures such as anti-inflammatories, bracing, and modification of activities, and has a positive EMG finding that is anywhere from moderate to severe, then typically we would recommend a release of that carpal tunnel ligament. The carpal tunnel ligament is the roof of that carpal tunnel. Underneath the median nerve, which is the nerve that runs through the middle of the wrist, are the tendons that move your fingers. Above that median nerve is the ligament. And the two ways of releasing that ligament. The standard of care, which is the old classic way of releasing the ligament, is an open approach, a small incision along this crease right here in the middle of the palm. This allows you to release the ligament and allow that nerve to become vascularized or breathe again to get its blood supply back and start to heal itself. Now, the newer way that we use here in releasing our carpal tunnels is through an endoscopic carpal tunnel approach. This requires two small incisions, one at the base of the wrist and one up here in the mid-palm. This allows us to put a camera within the wrist and look at that ligament, and under direct visualization release that ligament with a small micro knife without disrupting the skin over the nerve itself. I find that patients prefer this method because it's less invasive. There is not a scar in the middle of the palm, so it does not hurt patients that have to do any kind of manual labor or pushing off of the hand or wrist. And as far as the healing I do find that it does heal slightly faster, and there's less, and it's a better cosmesis for the patient. Either way is acceptable, but I find that the endoscopic approach is definitely a good option for patients who prefer that, and we definitely do offer that.